Hello, and welcome to today's webinar, Building Partnerships That Last, Working with TBI Model Systems, offered by the National Association of State Head Injury Administrators. I'm Maria Crowley, Director of Professional Development for NASHIA, and I'm going to be your moderator today. NASHIA's Coordinator for Member Services and Communications, Haley Cushion, is going to be our organizer. Thank you for joining us. For those of you that are not familiar with NASHIA, we're a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. A go-to user guide is available on the GoToWebinar website. It's a great resource for making the most out of all your live webinar experiences. To ask a question during our webinar today, please submit that in the questions pane in your control panel, and our organizer will forward those questions to us and we'll address those at the end of the presentation. If we run out of time, we'll respond to those questions via email afterwards. Continuing education credits for social work, certified rehabilitation counseling, as well as general certificates of attendance are going to be available for today's event. That will happen at the end of the webinar, and you'll receive an email and an evaluation with instructions on obtaining those credits. The webinar is also going to be archived for later access on our website. I would now like to introduce you to both of our presenters, and I think that you're going to be amazed by the work that happens on the national level, the work that happens in the states related to research and turning research into practice. With what they're going to share with you today, if you're not already aware of the traumatic brain injury model systems. First is Dr. Kate Miller. She's a rehabilitation program specialist with the National Institute on Disability, Independent Living and Rehabilitation Research, which we shorten to NIDILRR, which sits within the U.S. Department of Health and Human Services. Dr. Miller came to NIDILRR in 2003, already with a slew of experience in clinical, research, and teaching endeavors, and that experience has multiplied tenfold since the time she's been in that seat. She manages the TBI Model Systems Centers program. There are 16 centers she's going to tell you about nationwide. Dr. Miller has extended NIDILRR's national influence by establishing interagency agreements between the Department of Defense and NIDILRR, Department of Veterans Affairs, the National Institutes of Health, and most assuredly the Centers of Disease Control and Prevention, and then between NIDILRR and professional organizations like the American Congress of Rehab Medicine, the American College of Surgeons, and the Committee on Trauma, the American Academy of Neurology, and last but not least, NASHIA. Second, you're going to hear from Dr. Kristen Dams-O'Connor. She's the director of the Brain Injury Research Center at Mount Sinai and professor in the departments of Rehabilitation Medicine and Neurology at the Icahn School of Medicine at Mount Sinai, which sits in New York. This is one of the 16 model systems. Her research is focused on identifying mechanisms, risk, and protective factors for post-traumatic neurodegeneration with individuals with traumatic brain injury and repetitive head trauma sustained through sports, military service, and intimate partner violence, and some of you work in those areas. She's published over 100 peer-reviewed manuscripts and chapters on TBI treatment and outcomes, presented her research internationally. Her clinical expertise is in neuropsychological assessment and intervention for individuals with neurological diseases. She's provided training in the delivery of evidence-based cognitive interventions for thousands of clinicians across the world. So you are in good hands with these two women, and I would love to say welcome to you both.
Thank you so much. It's a pleasure to be here.
Excellent. Kate, I'm going to turn it over to you.
Thanks, Maria. Thank you so much for that lovely introduction, and more importantly, for highlighting the TBI Model Systems Centers program for this webcast. So my name is Kate Miller, and I work at the National Institute on Disability, Independent Living and Rehabilitation Research. You've heard we shorten that to NIDILRR. NIDILRR is an agency within the Administration for Community Living. and that falls within the U.S. Department of Health and Human Services. Next slide, please. NIDILRR has funded 3 types of model system centers for quite some time now. The first was actually the spinal cord injury model systems. That began in 1970, followed by the TBI model systems in 1987, and then finally the burn injury program in 1994. Next slide. So these programs are grant programs. They're competed every 5 years. And to compete for a TBI Model Systems Centers grant, one must already have in place a multidisciplinary system of TBI rehab care. This is across the continuum, so it includes emergency medical services, acute neurosurgical services, comprehensive inpatient rehabilitation, as well as this long-term interdisciplinary follow-up care in the community. Next slide. So the TBI Model System Centers, each of the 16, is required to do these things. They must conduct one center-specific study on TBI rehab. They must participate in at least one collaborative study. We call them module studies. They must enroll and follow people with TBI in the TBI Model Systems National Database. We'll be talking quite a bit about that in a moment. And finally, they must collaborate with the Model Systems Knowledge Translation Center. Now, there is an additional opportunity. It's a separate grant program, and Model System Centers may compete for that funding to conduct larger collaborative studies. Next slide. This just gives you a visual of where these model system centers are currently located. Next slide. And this is the list of the centers that are currently funded. This 5-year cycle began in 2017, and it will soon be recompeted. Next slide. These are what we call TBI Model Systems follow-up centers. Now, these are centers that were funded at an earlier time, but are not currently funded as TBI Model System Centers. But we do provide monies for these centers to continue to conduct their follow-up surveys on people that they had already entered into the database. Next slide. I wanted to just give you a quick look at the types of research that the model system centers are doing at their own centers. These site-specific studies. With 16 centers, you see that there are 16 studies currently underway, and 10 of those are randomized controlled trials looking at a variety of interventions listed here. The others fall into this general category of studies that look at assessment and prediction of outcomes. Again, quite a range of topics. Next slide. This slide lists the topics of that multi-center research, both the small module studies as well as those larger, the larger study that's separately competed. Again, you can see a huge variety of topics from characterization and treatment of pain, caregiver resilience, a study looking at menopause, return to driving, physical activity. Really, it spans the gamut. Next slide. I wanted to take a little bit of time to look more deeply at the TBI Model Systems National Database. So first, kind of what is it? It is a prospective, longitudinal, multi-center study to examine the course of recovery and outcomes following this coordinated system of care that I mentioned earlier. Really, the objectives are to study the clinical course of individuals with TBI from the time of injury until their death, to evaluate the recovery and long-term outcomes of those individuals. And finally, to establish a basis for comparison with other data sources. Next slide. This is the inclusion criteria for entry into our participation in the database. And generally, these are people who are 16 years of age or older at the time of their injury, and they do tend to be people who have moderate to severe TBI. We do have some in the database that are that have complicated mild TBI. Next slide. I wanted to make sure that I was being clear about this population of people that are in the database. So I wanted to go out a bit to the 60,000 foot level and take a look at where this cohort sits. So CDC has helped us to understand that at least 2.8 million traumatic brain injuries occur in the United States each year. Now, of those 2.8 million, almost 56,000 people die as a result of that injury. 280,000 plus are hospitalized because of their injury, and almost 2.5 million injuries are seen in the emergency department. Now, we have no way really of putting a number on those who either don't receive care or who receive care in another setting, such as their doctor's outpatient office. Next slide, please. Those that are enrolled in the TBI Model Systems National Database are represented by this dark bar. They are those that are hospitalized and then subsequently entered into inpatient acute rehabilitation. Next slide. So let's take a look for a moment at the methodology used for this database. It includes repeated surveys of individuals post-injury at regular intervals. Now, the first is at the time of their inpatient rehab discharge. In addition to the survey, information from the patient's medical record is also used. And after that, surveys are conducted at 1 year, 2 year, and 5 years post-injury, and then every 5 years after until death. Next page. So the data categories that are generally kind of summarize the data that's included are demographic characteristics. We include causes and severity of the injury, nature of a variety of diagnoses, some characterizations of characteristics of treatment. We look at impairment, we look at health and behavior measures, measurements, we look at disability and at participation. Next slide. So as of last month, the database includes 18,564 people. And as you look down this slide, you'll see the number of follow-ups that have been conducted on those who've been entered into the database. Now, you remember from an earlier slide that the TBI Model Systems was established in 1987. So in those early years of existence, folks were beginning to be enrolled in the database. And so we now have 115 people that have been able to be followed for 30 years post-injury. It's a very, very rich data set. Next slide. At least 155 studies have used the TBI Model Systems database as the source of their data for study. And these have focused on a variety of topics, but I've just provided a few here. Many have looked at the natural history of TBI outcomes, also an important look at comorbidities, the epidemiology of moderate and severe TBI. We've looked at predictors, both of outcomes as well as comorbidities. We've looked at the validation of measurements of severity as well as validation of outcome measures. And of course, looked at the longitudinal change over time. Next slide. Now, the database is one source of results that are included in peer-reviewed publications, but then, of course, we have all of the rest of the work. Those are the site-specific studies as well as the module or collaborative studies. So we have at least 400 peer-reviewed publications resulting from this work over time. And I've suggested at least 5 categories, if you will, of work that have been the focus of this. So they include quite a bit of interventions research leading to evidence-based practice, access to healthcare, and this of course includes telehealth models. This work has looked at new and improved measures of health and function, the epidemiology of comorbidities such as depression and substance misuse, improvement and decline of functioning over time, and it brings us back to interventions. Next slide. This work is also provided for TBI practice parameters. I'm just providing a few examples here. Post-traumatic seizures, practice parameters for post-traumatic agitation, for spasticity, for substance misuse, family function, for driving. And very recently, guidelines for the treatment of disorders of consciousness. Next slide. This work of the TBI model systems has also led to innovative TBI interventions. Again, this is only a sample, but I've included here DVT prophylaxis, the use of amantadine for disorders of consciousness as well as for irritability, the adaptation of acute rehab for older adults, quite a bit of work on cognitive rehabilitation, caregiver support, and telehealth support. Next slide. The model systems have also have done quite a bit of work in creating novel diagnostic procedures as well as measurement instruments. And these are just a few, you know, the lifetime measure of lifetime TBI, post-traumatic amnesia, neurobehavioral functioning. We've looked at disability, attention, agitation, of course, participation. Next slide. TBI model systems work has also looked at the identification of risk factors for mortality, for early mortality, risk factors for adverse outcomes, such as these. Next slide. Model systems research has looked to characterize recovery trajectories at 2, 5, and 10 years post-injury. And this is a list of just a few. We've looked at trajectories for functional independence, satisfaction with life, cognitive abilities, employment, and even residence. Next slide. This rich data set has led to a significant amount of interest, but also some questions like, are the findings from this database generalizable? Does it actually reflect the larger population of people with TBI in the United States? I mean, we know by definition that the database focuses on moderate to severe TBI, but is it a biased sample of cases? So to address this, the CDC joined with NIDILRR and the model systems to do a comparison of the model systems data set with UDS and e-rehab data. These studies gratefully alleviated this concern. In fact, it led to the development of a weighting system so that the national database can represent the population of those who receive inpatient rehabilitation in the US. Next slide. We've then been able to use this weighted data set, this nationally representative data set, to look at long-term outcomes and provide national estimates of prevalence and outcome post-moderate to severe TBI. And in fact, the results of this work have supported the work of many others to suggest that TBI is a chronic condition. So, for example, at 5 years post-injury, we know that 22% of those who survived the injury, who went on to receive inpatient rehabilitation, at 5 years post-injury, 22% of those people have died. An additional 30% have actually become worse relative to their functioning at 1 or 2 years post-injury. Now, 22% have stayed the same from their functioning at 1 or 2 years post-injury, and 26% have actually improved from the functioning at 1 and 2 years post-injury. Next slide. This weighted data set, this nationally representative data set, has helped us to understand that this cohort of people actually die an average of 9 years sooner than the general population. And we know that they die of causes that set them apart from the general population. For example, they're 50 times more likely to die of seizures. They are 11 times more likely to die of accidental food poisoning, and so on. We know that 57% are moderately or severely disabled by 5 years post-injury. 55% don't have a job, although they had a job prior to their injury. We know that 50% have been admitted to the hospital at least once. And we know that 33%, now that's a third of these people rely on others for help with everyday activities. So this data set has been, a very, very important accomplishment for having a better understanding of moderate and severe traumatic brain injury as a chronic condition. Next slide. So some years into funding these model systems, NIDILRR realized there was a critical need for funding a separate center called the Model Systems Knowledge Translation Center to help with these three things, to enhance the relevance and the visibility of model systems research, to communicate this research to a variety of stakeholders, and to integrate stakeholder input, both in the development and the dissemination of products as a result of this model systems funding. Next slide. I wanted to give you a look-see here at the model systems the Model Systems Knowledge Translation website. And you can see a list here of examples of the products that are available at the website. There are fact sheets, slideshows, infocomics, videos. There are quick reviews, which are brief summaries in user-friendly language of research work from the model systems. Next slide. I wanted to give you a sense of the topics that are represented in these products. There is alcohol in TBI, balance problems in TBI. Next slide. We're just kind of scrolling through this, this web page here. It changes in memory. You see the list here, driving. There's even a look at concussion, emotional issues after TBI. Next slide. Fatigue and headaches post-TBI, loss of taste and sense. Next slide. There's a focus on severe TBI, sexuality, spasticity. Next slide. There's even a voting tip fact sheet for folks who have a TBI. Next slide. So just a look at moving forward. We last year funded a 5-year grant to develop a chronic disease management model for people with TBI. We are currently in the process of recompeting the TBI Model Systems National Data and Statistical Center grant, as well as the Model Systems Knowledge Translation Center grant. And finally, next year, we will be recompeting the 16 Center Model Systems program. Next slide. I wanted to just mention before I give you my contact information that we also are moving forward with significant efforts to leverage the Model Systems database, including this focus on national estimates. For example, we have joined with the CDC to be involved in the Healthy People 2030 initiative by introducing a TBI objective. We are looking at efforts to merge the national database with other databases, for example, the National Trauma Data Bank. And we're continuing in our efforts to develop common data elements for research. Next slide. So please do feel free to reach out. I have contact information here for me, as well as for the Data Center and the Knowledge Translation Center. Thanks so much for your attention. We look forward to hearing from you. So I will hand things over now to Dr. Kristen Dams-O'Connor. She'll be talking about the way that the Model Systems is collaborating with others in the community. Thanks, Kristen.
Thanks, Kate. So what I'm going to do with my time is I'm going to give only 3 examples of ways that TBI Model System Centers have partnered with states and state agencies. And then I'm going to spend most of the time talking about the very preliminary results of a study that we launched with NIDILRR funding and with a lot of support from NASHIA. Next slide. So I'll start with Ohio State, which is really in a lot of ways a model example of how a TBI model system can partner with a state TBI program. So the Ohio Valley Center for Brain Injury Prevention and Rehabilitation has since 1997 housed the Ohio Regional TBI Model System, and since 2013 has also housed the Ohio State Brain Injury Program. And this co-location of these programs has really provided an opportunity for translation of the applied clinical findings from the model system and other work. I'll also note that Monica Lici, who oversees the research staff, is president of NASHIA. So again, a very great example of how these groups can work together. Just a few examples of some of the projects that have benefited from these partnerships. The first is, as Dr. Miller noted, in part the development of the Ohio State University TBI identification method, which is a lifetime screener for TBI. And they have used this for screening and surveillance for traumatic brain injury and in some cases acquired brain injury across several states. With funding from HRSA and TBI Model System, They've developed a booklet called Accommodating the Symptoms of Brain Injury, and is now available for use across state agencies. They have worked on developing pre-service training of social workers that has been done with both Model System and Ohio Brain Injury Partnership Funds. And another thing that I think this group has really led the field on is understanding and intervening upon substance use disorders in individuals with brain injury. So Dr. Jenny Bogner has led a lot of this work and has developed screening and brief interventions for substance misuse among patients with TBI. And this is really one of the few substance use treatment programs specifically designed for people with traumatic brain injury. And I think across the board, this group has done a lot of work investigating how state policy affects traumatic brain injury outcomes. And I'll thank Dr. John Corrigan for helping me to describe just a snapshot, I think, of the work that they've done. Next slide. Okay, VCU, Virginia Commonwealth University, has also done quite a bit of work that really warrants mention here. They have, in partnership with the Virginia Department of Aging and Rehabilitative Services, with mentor funding, they have developed a state TBI data plan. So this has allowed for them to work to describe how to access and how to use brain injury information among the state agencies. They have made recommendations for actually harmonizing TBI data about prevalence of TBI from multiple different sources to get more accurate and more comprehensive understanding of the true prevalence of traumatic brain injury. And they have worked together to make some recommendations for data use, how to use these data to expand and advocate for services that we know are needed. They have also, along with many of the TBI Model System centers, collaborated on an exhaustive systematic review of TBI and opioid use, led by Amy Starosta, and that is a manuscript currently under review. And they have also conducted now a statewide survey to characterize opioid use and misuse among individuals in the state of Virginia with traumatic brain injury. They also host a wonderful brain injury conference, and the preliminary findings from that statewide survey were presented there. Next slide. So I'll also talk just for a moment about some of the work that we've done at the New York TBI Model System at Mount Sinai. We also have a brain injury screening questionnaire, which is used to characterize lifetime exposure to traumatic brain injury, that was developed in part with TBI Model System funding. And we've partnered now with New York State and our mental health and substance use agencies, and agencies actually in several other states, to screen for traumatic brain injury. We have now partnered with juvenile justice facilities in the state of Texas to screen for traumatic brain injury among incarcerated youth, and we have found alarmingly high rates of traumatic brain injury that is often undiagnosed, unrecognized, untreated, the vast majority of which actually preceded first incarceration and first criminal offense in that population. We partnered in a science implementation project with the Alabama Department of Rehabilitation Services and the Alabama Head Injury Foundation. Our colleague, Dr. Theo Saucides, traveled to Alabama and trained the staff in implementing a program that was developed at Mount Sinai in part with TBI Model System funds called Short-Term Executive Plus. It's an evidence-based comprehensive neuro rehab program that really targets executive functioning and social and emotional regulation challenges after brain injury. That science implementation project in partnership with the state of Alabama really gave rise to similar efforts in Georgia, in Massachusetts, where we worked with one of the Veterans Affairs medical centers to tailor that intervention for individuals who were returning from active duty, and who were challenged by reintegrating into civilian life. And we also modified the program slightly for incarcerated youth in partnership with the state of Texas. and developed what we now call Y-STEP, Youth STEP. Right here in New York State, we have developed quite a few educational materials, and this is not at all unique to our model system. As Dr. Miller showed, the model systems across the sites have developed so many really useful information sheets and fact sheets and resources that are readily available, easily available for the states to use. We've partnered with many states and many other model system centers to advocate for TBI to be recognized as a chronic condition, with the goal of ensuring that chronic care and long-term care is available to those who need it. And we've also worked to help educate state agencies and other entities about areas where the research is really rapidly evolving, such as with chronic traumatic encephalopathy. We have over the years identified more and more areas where our interests and efforts overlap with those of NASHIA, including working in the juvenile justice facilities and with post-incarceration resource facilitation. And most recently on this survey that I'm going to talk with you about for the next few minutes, where we investigated the impact of the COVID-19 pandemic on individuals with TBI. Next slide. This was a NIDILRR funded effort that was led by our group at the Brain Injury Research Center, the New York Traumatic Brain Injury Model System, and colleagues at Kessler. And we, with a lot of help from NASHIA, sent a survey out across the United States in hopes that individuals with brain injury would respond and tell us about their experiences during the pandemic. So as you can see here, this is just a quick snapshot of the sample. You'll see a photo there of Anel Avalis, who oversees our TBI model system and who ran all of these descriptive statistics for us to look at together today. So the sample is pretty large, over 1,400 people, reasonably distributed across the age range, mostly male, mostly have some college education, predominantly US born, and the majority are white, but some great diversity in the sample. Only 27% were employed for wages at the time of the interview, and 55% reported a loss of wages since the pandemic started. Next slide. Now, the severity of injury in our study sample was leaning a little bit more towards the moderate to severe side, at least when you compare this to the CDC's nationwide estimates, which suggest that about 80% of all TBIs are mild. Our sample leans a little more severe. This is likely a result of our recruitment avenues. You'll note too that 56% had 2 or more traumatic brain injuries. Next slide. So these questions were asked of those who work. So if someone said yes to the first question about whether they're employed, they were sent to then answer these follow-up questions. You'll see that in our sample, a lot of individuals are reporting on-site work at least a few days per week. We are interested to understand the level of exposure to COVID or concerns about COVID exposure during the workday. Almost half of our sample required some face-to-face exposure with other individuals, and about a quarter said that they, at least weekly, were spending time in closed spaces, such as sharing offices. And based on the responses to questions about exposure to infection, it sounds like in our sample we have quite a few essential workers. Next slide. We were also interested in living conditions at home. Most of our sample live in homes with 3 to 4 people at least. About half seem to have essential workers living at home, most of whom come home each day. Next slide. So here we have 2 figures where we asked about worry and isolation. The first is about how worried are you that you're going to get COVID-19? And I'll say that for those who were previously infected, we asked, are you worried that you will get it again? And these are just raw numbers that you see here from a total sample of about 1,300 people. Well over half feel at least somewhat isolated. You'll see that on the table to the right. These are individuals with TBI. We don't yet know how they compare to the rest of the population. I will say that the methods that we used in this survey were borrowed from a survey developed by colleagues in Texas that has been launched nationwide. And so we do actually have a nationwide comparison sample. We have not even begun to crunch those numbers yet. At this point, we're just describing our results in our sample of individuals with brain injury. So we don't yet know how these responses compare to the general population, but soon we will. Next slide. Here, we were interested to understand people's experiences in terms of just overall disruption and functional change. We see, not surprisingly, a lot of people have found the past year to be quite disruptive to their daily lives. And then the table that you see on the right, we specifically asked about, due to the needs for social distancing, for sheltering in place, worries about getting infected, etc., have you noticed changes? And unfortunately, the wording of the question is not ideal, but we do see that quite a few people report changes in various aspects of cognition and behavior. Next slide. Here, in this survey, we used very commonly used well-validated measures of depression and anxiety. These measures have widely validated cut points that allow us to categorize individuals into mild, moderate, severe depression. And you'll see from the table on the left that only 19% of this sample is not depressed at all. On the right, you see that only 15% are not anxious at all. Again, these are based on clinically validated cut points for commonly used scales. And looking at this alone does tell us that mood was overall probably challenged, and we are concerned that it was uniquely challenged in individuals with TBI during the pandemic. Next slide. We were interested to understand the overall disease burden. How many chronic conditions, what types of chronic conditions do our research participants deal with on a daily basis? We were especially curious to know about interruptions to care during the pandemic. As you see in the table on the left, we have a lot of comorbid conditions in this sample, and you'll see the first column, the yes column, indicates the proportion of people with each of those conditions. And then if a person said, yes, I have this condition, we asked, during the pandemic so far, have you seen a doctor? And you'll see that not everyone with a condition that you would think requires treatment sought medical care during the pandemic. The table to the right was intended to try to get a better understanding of the barriers related to care during the COVID-19 pandemic. You'll see that the most common barrier is fear of exposure to this disease, but others relating to transportation, availability of childcare, and inability to reach a provider, and several that pertain to cost, insurance coverage, ability to pay for needed medical care were also noted. Next slide. Here, there we go. Here we looked at finances. Our participants are reporting a lot of financial strain. So as you'll see here, nearly a third of respondents are finding it hard or very hard to pay for basic things. Only 13% are financially, quote unquote, comfortable with extra. And 1/4 of respondents had to cut back or cannot make ends meet. Again, we don't know how this compares to the general population. Soon we will. In the next slide, we looked at substance use. Now, there have been reports and some empirical evidence to suggest that alcohol use has increased during the pandemic. We didn't see that in this sample of respondents. More people are saying they drank less than saying that they drank more. This is a good thing. I wonder if it's related to that financial strain that is reported in that previous section, but it is somewhat reassuring to see. These questions, however, about prescription pain medication are quite concerning. We see that 14% reported using more pain medication than was prescribed to them, and 25% are using prescription pain meds that were not prescribed to them. These are clear risk factors for the development of an opioid use disorder. And so this is something that we certainly need to look into more carefully. Next slide. Now, here we have some findings that are particularly difficult to look at. We wanted to understand safety in the home. We have all read reports suggesting that domestic violence has increased across the globe during this pandemic. Here we see that only 30% of our respondents report that they are never physically hurt. About 1/4 say that they are regularly insulted or talked down to. About 20% are sometimes, fairly often, or frequently threatened with harm. And about the same proportion are telling us that they are screamed or cursed at. So again, we see from other studies that rates of intimate partner violence and domestic violence have increased. And we're really just beginning to understand the implications of the pandemic for individuals who are disproportionately vulnerable to violence at home, which includes people with disabilities. So irrespective of how these findings compare to the general population, this is clear evidence to us that this is an urgent opportunity for education, for intervention, for checking on the safety of individuals who are in potential contexts where they could be vulnerable to violence. The next slide is the last that I'll share in terms of findings from this study. This information pertains to experiences with COVID testing and vaccines. We see that about 11% were unable to get tested, and 9% tested positive at some point during the pandemic. Ending on somewhat of a high note, I hope we see that 78% report willingness to be vaccinated, which does exceed rates that have been recently reported in many demographics across the country. And we do hope that many of our patients who are safe to be vaccinated and who are comfortable being vaccinated will do so. Next slide. So, in closing, we want you to know that the Model System Centers are very eager to work with the state agencies. Not every model system has a funded state agency in their state, and not every state agency has a TBI model system, but our resources are really very often relevant to people with brain injury across the entire country. Next slide. One of the points that I was asked to make is that most, if not all, of the TBI Model System Centers have broad TBI research infrastructure and extensive clinical care infrastructure. And this is just an example from one of the 16 model systems, but we want to be resources for the state. So we're basically saying contact your nearest model system or any model system. The project directors and staff are really eager to partner on research efforts, on educational opportunities, on advocacy efforts. Again, just one of so many examples. The Mayo Clinic created a beautiful resource for explaining TBI and its effects in great detail. We use their resource. Clinicians and researchers at the Rehabilitation Hospital of Indiana have developed an extraordinarily impressive partnership with their state agency to provide resource facilitation for people with brain injury. Our colleagues at the TIER model system have created some amazing resources for people with TBI and their caregivers, almost all of which are translated into Spanish. Next slide. So in closing, this is who we are. If you go to the National Data and Statistical Center's website, you'll be able to find contact information for all of the model system project directors. That is my last slide. Thank you again to NASHIA for inviting us.
Thank you so much. You named some examples that I did not think about and have not heard about in some time that give me pause to think about some other things that we could be doing with states and model systems as well. Kristen, thank you so much. And Kate, you as well. You have heard from Dr. Miller about a very comprehensive and helpful overview of the whole NIDILRR and model system and some of the parts related to research and practice. You have heard from Dr. Dams O'Connor about some information from her own model system and some of the excellent collaborations that she highlighted with her that she has heard from the states she's spoken with. I want to finish up our webinar today with some examples that I have discovered or have known about from talking with states over the years. I, many of you know this already, ran the state brain injury program here in Alabama and have some personal experience with the model system that's located here in Birmingham with the University of Alabama at Birmingham. That partnership has only helped to strengthen the state program way back when we first started with providing at-home cognitive rehabilitation and our home-based model, and just has grown since that time. I can't say enough about our own model system. Just a few other examples to share with you from a national perspective and from a state perspective. We often think that things begin and end with money, and sometimes they do. I just wanted to mention the support that NASHIA has provided over the years with Hill Day. Every year in March, the Congressional Brain Injury Task Force hosts a congressional briefing. It allows states an opportunity to come to DC, learn about what's going on across the country from a variety of exhibitors and presenters, and then take the time to meet with their congressmen and women to share about the wonderful things that are happening in their states and to advocate for funds. NASHIA is in the middle of that effort and provides and sponsors a lot of those visits, and on a daily basis through our policy team encourages funding increases across all the programs that touch traumatic brain injury. Not only the state programs, but also model systems funding through NIDILRR, the protection and advocacy funding, and even funding with the Centers for Disease Control. So I think that's important to note because without the money, we couldn't do what we do and the things that you guys do so well, and we're happy to do that. We have recently changed people, but have been involved with the National Data and Statistical Center Advisory Committee for a number of years. That happens with Cindy Harrison Felix and her peers. Kristen has told you and Kate have told you a little bit about some of the efforts through the Knowledge Translation Center. We have in the chat already a number of folks that say, I love the fact sheets. Those are used across many states and at the federal level to educate some of those partners that I mentioned at Hill Day, and a lot of individuals in states with traumatic brain injury and their families and some of the community providers. So thank you for those. Please continue to produce those. Kristen also mentioned the Combi, and Kate has talked a little bit about some of the tools that are available there. States use some of those tools in the work that they do. There are a number of things there. I know we have used the Mayo Portland Adaptability Inventory in a number of different ways as an example. Kristen told you about the COVID study that's being conducted, which is fascinating and startling, some of the results that you shared, and I can just see that being the tip of the iceberg for a lot of other things, you know, to come with some of the information you just shared. NIDILRR has partnered with the ACL TBI Technical Assistance and Resource Center in producing a document that really highlights some of the personal challenges that individuals with traumatic brain injury have described experiencing. That is coming out later this week, and some of the preliminary information that Kristen shared with you is within that document. So I think that's a nice companion tool, because some of the people that were interviewed also participated in the COVID study that Mount Sinai conducted. There are special interest groups within the model systems, and one of those is chronic conditions, and one of our NASHIA staff, Judy Detmer, has been recently involved with that particular special interest group, which I think is going to lead to some great things. And in the documents pane, you have a sample of a shared product, which is a tip card for physicians that you guys can access, that was produced through the American Congress of Rehabilitation Medicine and Craig Hospital and NASHIA. So very happy to promote that. Next slide. And then just some state examples. Kristen said, that not all states have model systems. I would say certainly that states need to be partnering with the model systems in their own states, but the good news there is you can also partner with a model system in any other state. Because the work is pertinent to a lot of the work that happens within your state. So just keep that in mind. Some of these have already been talked about. I had them on my list, so I won't go through these, but the Accommodating the Symptoms of TBI booklet is used across just about every state over and over again, as is the OSU TBI identification method, which screens for a history of brain injury. Kristen mentioned that. A lot of states, including my own, have used the brain injury screening questionnaire, which she mentioned. There's a youth version and an adult version, and that's something online. It's a great tool. She talked about the emotional regulation intervention and the pediatric model. So I won't head there, but was very proud to see that you mentioned Alabama, because we loved that work, and a lot came from that effort. But some of the other examples states shared with us is advisory council representation. States that have traumatic brain injury advisory councils hold a seat for their model systems partners, and it's so helpful to hear from them. A lot of the model systems also have advisory councils and have state program participants join them with that work. So that works both ways, and I think is a good example of partnering. States have used their model systems to conduct needs and resources assessments across the years, state plans, strengthening and evaluating their state plans. They've used their model systems for specific program evaluation and data-driven outreach. One that I find particularly fascinating is sometimes states struggle to meet their cost match with grants. There are states that use their model system non-federal funds for that match, which I think is interesting. Moss Rehabilitation is currently working with the state program in Pennsylvania on a telehealth pilot that's yielding some very promising results. VCU has a caregiver resilience project that they have worked on with the state of Virginia and DARS. Mayo Clinic partnered with 3 states to produce a survivor advocacy project that a lot of states still use today. We have used it here, but I know a number of other states, Iowa and Minnesota for sure, have also used that, and I believe Michigan as well. And then states have used the model systems to help them identify tools to use for resource facilitation. I cannot tell you how many times we've called upon model systems staff for training, education, supports. Kristen mentioned to you one of the oldest brain injury conferences that used to be called the Williamsburg Conference, that has model systems right in the center of it each and every time that's hosted. But states have used the model systems to talk about opioids and substance use disorders, behavioral health issues, chronic conditions, medication management, you name it. We have called upon the states. Before we even got on this call, I was asking about some things that are coming down the pike that NASHIA is wanting to do, and I just cannot emphasize how important the model systems and the state programs partnerships can be. And I feel like there are many other opportunities, still that we can explore. So with that, Haley, if you will, move to the next slide. I think it might be a good time to address some questions, and I'm just taking a look to see what else may be in the Q&A. And I had a few questions as well as I'm taking a look. What is the Williamsburg Conference called now is one of the questions, and I should know the answer to that, but I do not. Do one of you know? You've stumped us. I'll find out the answer to that. Kate, this is a question for you.
Okay.
If states wanted to use the national database in some way, is there a mechanism for that to work?
Indeed, absolutely there is. There are actually two ways to access a de-identified data set. The one way that we're easy to promote, quick to promote, is being in contact with the National Data and Statistical Center. I have the web address on the last slide that I presented. And yes, there's an access form, that one-page access form that needs to be filled out, and then the data center will work with the folks who have requested the data to ensure that they are accessing the needed variables. They will then de-identify the data set and send it on after completion of a data use agreement. So yes, it's easily accessible by public request.
Awesome, thank you. Another comment about the fact sheets and the info comics. The videos and multiple modalities of learning are fabulous. They are very excited that they're also translated into Spanish, with a big thank you to you guys. Heading Forward is the name of the Williamsburg Conference now. Thank you, Chris. I knew it had changed names. There's a link for that in the chat. Are there other things that either we at NASHIA or that states can do to support model systems efforts related to mild TBI? You know, those that don't enter the traditional trajectory. And I know you mentioned concussion, Kate, I heard you, but are there other things that you can think of that we could help to support that?
Thanks, Maria. I'll give a stab at this, but Kristen might have some ideas as well. So certainly most of our, if not all of our model systems centers work with people with mild traumatic brain injury if services are needed. However, the TBI Model System Centers program, established and funded by NIDILRR, really is to serve and to conduct research with people with moderate and severe TBI. So while you may have seen the list of fact sheets to include that one on mild TBI, the focus of the research and the knowledge translation efforts are very largely focused on moderate and severe TBI. Kristen, do you have anything to add to that? You're on mute.
Muted.
Am I unmuted?
Yes.
Okay, good. I think that this is one of the reasons that Maria had the good idea of just making that point, that a lot of the model system centers do have very broad research programs that include the TBI model system and include a lot of other research projects. And we are very interested in sharing the knowledge that we gain, and also making sure that we address the questions that matter and that would be useful for the states to know. So reach out, and we would love to work together.
Excellent, thank you both. A question for NASHIA: is NASHIA advocating for all physicians to better report mild TBIs? In Delaware, 75% of mild TBIs do not show follow-up care. Yes, NASHIA does advocate for that. I would point specifically to support in terms of policy for the concussion surveillance project that the CDC has been hoping to have funded for the last several years to get at that very thing. But that's something NASHIA encourages across states as well. That's a big challenge.
Mhm. I would just add to that, if I could, that there's an enormous advocacy effort there too. I mean, in order to get into the TBI Model Systems national database, you had to have received inpatient rehabilitation at a facility that provides comprehensive brain injury inpatient rehabilitation. And I think Kate had a slide in her deck that showed the huge component of that triangle of individuals with brain injury that includes those that are perhaps not even diagnosed, but who do not receive care. A lot of people are discharged from the emergency room. Maybe they're monitored for a day or two if there's a positive intracranial finding, and then discharged home, sometimes without referral for follow-up. And we know from some of our other studies that many individuals, although most with an uncomplicated amount of TBI are expected to recover fully, not everyone does. And there is a lot of advocacy needed there to ensure that everyone with a brain injury gets the care that they need.
It takes checking in at all those points, while they're still in the hospital, before they head home, once they get home, and then all along the way, which is where some states more fully utilize their trauma registry, to connect people to services once they're home. If states don't have that in place, that's a bigger challenge, but there are some pre-discharge models within states, to help people access services once they come home.
And before we move on, I just want to say that the slide that in my slide deck that Kristen just referenced is with thanks to John Corrigan. Those two slides with the large triangle are essentially his slides, and he has given me permission to use them.
John Corrigan has his own fan club amongst the state programs. People love all the support they get from him, and he's just incredibly helpful. But it is a big challenge, as we were talking about. One additional comment here I see, follow up to the last one, referral for follow-up care needs to be made mandatory along with a neuropsychological examination. Any comments there?
I'll leave that for Kristen, our clinician.
I think that I agree. It needs to be, it at least needs to be offered. And I think that there's an educational opportunity there too. Not all referring physicians know what a neuropsychological exam might entail. They may not realize that a brief neuropsych evaluation for someone with a milder injury could inform early management and could, we think in some ways, maximize their outcomes. It can never hurt to refer. We know there are a lot of care disparities that make that challenging, but to allow the frontline clinicians who see patients with brain injury to be aware of these services and even community resources would be an amazing, amazing goal to work toward.
That's something that happens within some states that know the value of having a solid neuropsychological assessment and a feedback, that's really the gold standard in our state, full on or abbreviated. But it's such a useful tool and something that should be encouraged more. It's something we encourage within our own vocational rehabilitation system, as opposed to getting other kinds of evaluation, because it really gets at, as you guys know, functional issues and specific challenges in a way that nothing else does. A question about registries. Our state does not have one. Are there suggestions for those states to find a workaround to acquire that needed information? That is a question we could talk about for a really long time. There's a tool that will be released very soon from a work group that's been addressing using data to connect people to services within the Administration of Community Living's TBI grant program that may help with answering some questions about traditional registries and then some workarounds for voluntary registries and other ways to link people to services that might be useful to you. please feel free to reach out to me and we can, share some information soon related to that. One last question to ask you guys before we wrap up today. Any kind of closing comments that either of you might want to make about what states could possibly do to help support NIDILRR in the model systems that you can think of?
Well, it's a great question. I'm often kind of thinking about it in the other direction because that's where I sit. I think establishing those contacts that will, we're talking about rubbing elbows, really, people getting to know people, folks in the Model Systems Center getting to know their state partners in their own state or in perhaps other states, so that both can be used as a resource. And I think about really input from the state programs to the model systems to help inform research, and also in the other direction to use the state partners as avenues for dissemination of the research and its products. So I think, yes, build relationships, get to know each other, and then those are only two examples of ways that the partnerships can be beneficial.
Great, thank you. Kristen?
I'm sure Kristen has thoughts.
I think we were both kind of taken aback by the generosity of the question. We kind of come into this thinking, how can we support the states? NIDILRR has really distinguished itself as a funding agency that funds work that will directly benefit people living with disabilities, and it therefore receives grants and funds groups that want to do work that is going to help people living with disabilities, that is going to get into the hands of people who can use it. And I think that is where the states can help us the most. It's helping us to translate our research into advocacy efforts, into clinical practice change, helping us to monitor whether we're meeting our goals of sharing the research that we do, helping us to use our research to strengthen advocacy efforts. Let us know how we're doing, and if our studies aren't hitting the mark in terms of where the real priorities are, we want to know about that. These are 16 centers of researchers and clinicians who are fully dedicating their careers to helping the lives of people with brain injury and their families. So that's what we're here for. That's what we want to do. And if there are ways the states can help us with that, wow, thank you for the generous request and question.
Well, thank you both. Well, one certainly can strengthen the other. I think it takes both of us to make the best system that we can for individuals with brain injury. And I thank you so much for being with us today. I cannot tell you how much I appreciate it. I hope this has been helpful to all of you that are listening. Haley, if you'll go to the next slide, we'll just wrap things up very quickly. I just, wanted to mention that if you have any interest, NASHIA has other training opportunities. Stay tuned for information about those through our webinars, our podcast series, our YouTube channel, our Leading Practices Academies, and some of the customized workshops that we host. We're also hoping that you will save the date for our annual event, which is the State of the States Conference, which will be September 20th through the 24th. As you can see, registration details are coming out to you next week, in fact. We'd love to have you be a part of that. Some of our Model Systems partners present at that event, and you can hear more specifically about some of the work that happens within those. We thank you for taking time to view our webinar today. Please contact us if you need any notice of future events. And of course, our webinars are always archived and available online, and we would love to have you as a member. Please give us a visit at our website, and don't forget to complete your evaluations at the end of the webinar. Have a great day, and thank you.
Thank you.
Yeah.